Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
Tonight, we are focusing on gastroesophageal cancers. These are really two separate cancers, but as you'll hear, they're treated in very similar ways, and sometimes there's a bit of confusion between the two. They are relatively common cancers. Stomach cancer, for example, is the fifth most common cancer worldwide. And in the U.S., esophageal cancer is actually perhaps a bit more common. While not as common in the U.S. as around the rest of the world, gastric cancer is often diagnosed at an advanced stage, making awareness, early detection, and advancements in treatment ever so much more important. Our show tonight will focus on the progress being made in research and care, and we hope that this will be helpful to many of you. That being said, I'm thrilled to welcome to the show our guest, Dr. Raghav Sundar. Dr. Sundar joined the Yale faculty just under a year ago. He's a medical oncologist at Smilow Cancer Center and an associate professor of medicine at Yale in the Yale Cancer Center. He has a relatively unusual path to us, and I'm going to let him describe that in just a minute. Raghav, thank you so much for being here with us tonight on Yale Cancer Answers.
Thanks for the introductions, Eric, and having me on. It's great to be here.
So since I didn't get into it in my introduction, maybe you could tell us a little bit about how you got to Yale and where you're from.
Thanks, Eric. You're right. It is a little bit of an unusual story. So I was born in India and moved to Singapore to do high school. And I was in Singapore ever since. I did my training in medical school and then specialization in oncology. I also did a subspecialist training in experimental therapeutics and early phase clinical trials in the UK in the Royal Marsden, and then came back to Singapore to do a PhD in gastric cancer. I was working as a translational physician scientist in Singapore, in the Singapore Gastric Cancer Consortium, which is a group of physicians, surgeons, and scientists that were working together to answer the most difficult questions that were there in gastric cancer. And a couple of years ago, my boss and mentor, Dr. Pamela Coons, approached me, and we had a little bit of a chat and saw some opportunities at Yale. And one thing led to another, and now I'm here. So I
was going to say, and it's not terribly often that we have people recruited from around the world, and we heard about this from your boss, Pamela Coons, who's been on this show before. And I will tell you that when we heard her talk about you, we were immediately enthusiastic.
Thanks. It's been great. I spent a year here. A lot of the work that I'm doing is very similar to what I was doing back in Singapore, which is essentially seeing patients with gastroesophageal cancers, opening clinical trials in this space for patients to have an opportunity to get new drugs, and then translational work, discovering biomarkers and therapeutic targets that we try to develop new drugs for.
And our audience may not be familiar with this, but the Singapore medical community, and in particular the medical oncology community, is actually quite sophisticated. There are many extraordinarily well-trained physicians in Singapore. That said, I would bet that this feels like a very different kind of place to work, and that there are probably more opportunities available to you here. Is that the case?
Absolutely. I think there are many similarities in the way things work. I think academic medical centers across the world often have more similarities than dissimilarities, but the opportunities that I've had at Yale have been fantastic, and it's been a really great experience so far.
And just before we get into gastric cancer and esophageal cancer, both in terms of epidemiology and treatment and research, did you move here with a family?
I did. I moved with my wife and 2 children, and they are having a great time settling down here as well. We have 4 seasons now, which we didn't have in Singapore.
Yeah, no, that is true. Although I dare say that our orchids are not as beautiful as they are in Singapore, where really the flowering plants are just so lush. All right, so let's talk about gastric cancer and esophageal cancer. First, maybe you could tell us why there's both overlap and maybe a little confusion between the two.
Absolutely. So, for those who aren't very familiar with this area, the esophagus or the food pipe has 2 separate parts to it in terms of the way it looks under the microscope or the histology. There is the upper part of it that looks very similar to the oral cavity or has a squamous lining, and the second half of it that leads into the stomach has a lining that's more similar to the intestines or a columnar lining, and that kind of determines the kind of cancers that develop in the esophagus. Across the world and in the United States, the second half of the esophagus develops cancers called adenocarcinomas, and this type of cancer has a biology that's very similar to the rest of the stomach. There is also some confusion because there is a separate entity called the gastroesophageal junction,
which is right where the esophagus and the stomach join up.
Absolutely. So this is right at the diaphragm, right between the chest and the abdomen, and that the cancers there in the past used to have a different sort of belief on the way they are managed, but now we kind of think that all the adenocarcinomas that form from the esophagus all the way down to the stomach are treated in the same way. And so this has confused a lot of people in this space, but that's kind of what we're trying to align globally to have some commonalities here. Yeah.
And of all esophageal cancers, how many of them are squamous, arising in the first 2/3 of the esophagus, and how many of them are adenocarcinomas?
Yeah. This actually varies globally. The squamous esophageal cancers are very much more smoking-related cancers, and they occur at a much higher incidence in Asia, particularly in China and Japan and Korea. The adenocarcinomas are much more common in the United States in the esophagus. These are more related to lifestyle changes and reflux. A higher body mass index or obesity leads to a higher rates of reflux, and that leads to junctional cancers.
Yeah, and this audience has heard us talk about high body mass index or obesity and its impact on cancer, and is familiar with the fact that obesity is associated with an increased risk of actually 18 different kinds of cancers, of which esophageal cancer is one of those. So in the United States, we have relatively more lower esophageal cancer, treated more like stomach cancer or gastric cancer. And if you combine all the lower esophageal cancers and the cancers that arise in the gastric lining in the stomach, I assume that that's a greater number than we see of the upper esophageal cancers. Is that right?
Yeah, that's right. In fact, I mean, if you look at global numbers, stomach cancer, which is more common in Asia, is actually the 5th most common cause of cancer, as well as cancer-related death globally. And the esophageal cancers, actually, if you add them up with the stomach cancers, the total number of deaths that are caused by this is actually very similar to the top few cancers like colorectal cancer or prostate cancer. So the numbers kind of add up. And this is a problem that's not just something that's something that we're dealing in the United States, but globally there's a very high burden of this disease that requires treatments, and we have new treatments that are coming up that's pretty exciting.
That's great. So just because we want to talk primarily about lower esophageal cancer and gastric cancer, maybe we can start by just talking very briefly about the upper esophageal cancers. And can you tell us a little bit about the treatment approaches for those cancers? And it's usually a multimodality approach that involves a number of different treatments and different types of doctors.
Right. So this part, because the upper part of the esophagus is right in the middle of the chest, it requires the best way to cure early stage esophageal cancers is to surgically remove these. But because it's right in the middle of the chest, these surgical approaches can be quite complicated. And therefore, we use treatments like chemotherapy and radiation to try and treat these patients preoperatively to improve the surgical outcomes. And more recently and increasingly, we also talk about organ preserving approaches where we don't necessarily have to remove the upper part of the esophagus, but we can actually deal with it with just chemotherapy and radiation alone. And that's typically how we treat the earlier stages of these cancers. In the advanced stages, then it's most likely treated with systemic therapies, with chemotherapy and immunotherapy being the most common backbones that we use to treat these cancers.
And this is a cancer where immunotherapy has played a role.
Absolutely. So this, interestingly, the squamous cell cancers of the esophagus are quite sensitive to immunotherapy, and they have now been incorporated into frontline treatment, which means that anyone who's diagnosed with an advanced esophageal squamous cell cancer would get both chemo and immunotherapy in the front line.
And do those patients have the ability to go on and be cured?
We don't use the word cure so commonly in these sort of cancers because it's not something that we see many patients with long-term survivals. But as with immunotherapy and many other disease types, we do have a small subgroup of patients who have long-term survival, even in the stage 4 setting. So increasingly, I think we are a little bit more aggressive and a little bit more optimistic when these patients start treatment.
But your hesitancy about using the word cure is really for patients with advanced stage esophageal cancer and does not apply to patients who have early stage disease, where you can use these treatments really with the hope that someone will go on and live a very long and healthy life.
Oh yeah, absolutely. So I was definitely hesitant about using the word cure for advanced, but in the earlier stages, we are talking about curative intent treatment, and these patients do have a good long-term survival.
And before we take a break, maybe you could talk a little bit about the symptoms that someone might have from esophageal cancer. And I think this probably applies equally well to upper and lower esophageal cancers.
Yeah. So the most common symptoms that we are taught about in textbooks is what we call as the difficulty in swallowing or dysphagia. This is very often the symptoms that patients with esophageal cancers have. But very often, the ones that are diagnosed have very vague symptoms of abdominal pain or low hemoglobin or bleeding in the gastrointestinal tract that's often picked up in blood tests. And then they have endoscopies done and find these cancers incidentally. So that's something that we'll probably talk about in the next part of the session, is that identifying these cancers early are not very easy because the symptoms that patients present with this sort of illness is not something that is very typical or specific for this cancer.
Got it. Well, we're going to need to take just a very brief break. And when we come back, we will talk about the treatment of both lower esophageal cancers and gastric cancer, which is somewhat different from what we've heard about. We'll talk about some of the newest research in this area. And we'll see where that goes. So we'll just be back in a minute.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where a multi-specialty team is dedicated to managing the diagnosis, evaluation, and treatment of prostate cancer and other urologic cancers. Learn more at smilowcancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. but when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to the second half of Yale Cancer Answers. I'm Eric Weiner, and tonight I've been speaking with Dr. Raghav Sundar, medical oncologist who treats gastrointestinal cancers at Smilow Cancer Hospital, focusing on esophageal cancer and gastric cancer, or cancer of the stomach. Dr. Sundar, as he was telling us, did most of his training and spent his early career in Singapore, and much to our delight joined us here at Yale about a year ago. We talked in the first half about upper esophageal cancer, and now we're going to focus on lower esophageal and gastric cancers. These are adenocarcinomas. And we were talking earlier about the symptoms of esophageal cancer. I imagine that the symptoms of gastric cancers are a little different when people come to medical attention.
Absolutely. So the cancers in the stomach have a lot more of a vague sort of symptoms that they present with. Patients can have symptoms of abdominal pain or bloating. More commonly is these tumors tend to be easy to bleed. And so most of the time, the way we detect this is that folks would have a blood test to look at the hemoglobin and be found to have anemia, and then they would get an endoscopy done, which will detect the cancer. So it's quite important to consider that an iron deficiency anemia that's picked up, that if there is a risk for stomach cancer, that they should get an endoscopy done to pick this up. There is no, in the United States, there's no formal screening that's done at the population level for stomach cancers. In other parts of the world, like in Japan and Korea, where stomach cancers are a lot more frequent, there are formal screening programs that are available, which is why here in the United States, most of the patients who get diagnosed with lower esophageal or gastric cancer are diagnosed at a later stage compared to those in other parts of the world.
And can you comment on why gastric cancer is so much more common in Japan and in Korea?
We don't have a single answer for this, but there are multiple hypotheses around the kind of dietary intake that has been seen in Japan and Korea, especially to do with the high salt and salted fish diet. But these haven't had very close associations. More commonly and more importantly is probably the role of Helicobacter pylori, which is a bacteria that's present in the normal stomach in about a third to about half of folks all over the world, but is known to be associated with the formation of gastric cancer in about 3 to 5% of people that have this. And so there's a lot of focus now on trying to eradicate the Helicobacter pylori, which is often detected either using a breath test or an endoscopy. And this can be eradicated with a course of antibiotics.
And isn't it also associated with an increased risk of ulcers in the stomach?
That's right. So the way that Helicobacter pylori leads to stomach cancer is through an inflammatory process, which can lead to ulcers as well.
Got it. So how is it that we treat gastric cancer and lower esophageal cancer differently? What are the treatment approaches?
So I would broadly divide the treatment into the way we manage early stage cancers and then late stage cancers. The early stage cancers are very much similar in terms of a multimodal approach that we use in esophageal cancers, with surgery being the mainstay of treatment. And the most important aspect of this is to use surgery to remove the tumor per se. slightly different from upper esophageal cancers is the role of radiation therapy, which is slightly less in gastric cancer, and we mostly use chemotherapy, different chemotherapy drugs, or what we call as combination chemotherapies, in a similar manner, both before and after surgery. Very recently, there was a trial called the Matterhorn trial that showed that the addition of immunotherapy to chemotherapy had a survival benefit. And so we have now started adding immunotherapy to chemotherapy, even in the earlier stages of gastric cancer.
Yet another cancer where immunotherapy has led to an extension of life, and the list just keeps getting longer and longer, which is all the more reason why we need to figure out how to get around some of the side effects with immunotherapy, which many of our colleagues are working on very intently. And so a patient might receive chemoimmunotherapy initially and then have surgery?
Absolutely. So the way we currently treat these patients is a combination of chemotherapy and immunotherapy, usually for about a couple of months, 2 to 3 months, after which they will go for surgery. And after the surgery, then they'll finish up the rest of the chemotherapy and the immunotherapy as well. And this has led to pretty high cure rates for earlier stages of gastric cancer.
And why is it that radiation plays less of a role?
There are many theories around this, but I think mostly it has to do with the fact that the systemic therapy drugs have started to become a lot more effective. In the past, a lot of the radiation was done to treat local disease, but the surgical techniques have improved as well, and therefore a mixture of just good chemotherapy with a good surgery does as well as, or similar to with the radiation therapy.
I see. And are there genetic predispositions to gastric cancer?
Yeah, so a majority of gastric cancers are sporadic, which means they're not hereditary in nature, but there are a small percentage of folks who have a genetic, hereditary mutation or a germline mutation that predisposes them to gastric cancer. The most common mutation is in a gene called CDH1, and patients that have, or folks that have a mutation in CDH1 have a higher risk of gastric cancer. I think more than the genetic predisposition is this concern about this rapid increase in the rates of gastric and esophageal cancers that we're seeing in younger patients below the age of 40. This is a phenomenon that we are seeing across multiple GI tumor types like colorectal cancer and pancreatic cancer as well. We're seeing the same phenomenon in gastroesophageal cancers, on seeing a lot of younger folks getting diagnosed with this cancer. And we don't really have a reason to explain this as of yet. A lot of us are doing a lot of research in trying to answer this question, but we don't really have a reason for this yet.
And I think, as you know, we're setting up a special clinical program very much connected to a research program to focus on young individuals with cancer, that is, individuals under the age of 46, because both in the area of GI tumors and breast cancer and some other cancers, there does seem to be a striking rise in the risk of young people developing cancer. You know, earlier, I think I asked you if there were genetic causes. I should have actually been clearer in the way I asked that question, because, of course, all cancer is genetic. It involves a change in the genome from a normal person's genome to the genome of the cancer. But not all cancers, and as you pointed out, most gastric cancers are not related to an inherited genetic problem. The interesting thing about the CDH1 mutations is they're also associated with an increased risk of a certain kind of breast cancer, lobular breast cancer. So many of these gene changes that people inherit can be associated with more than one type of cancer.
Yeah, absolutely. You're right about this. Well, as you said, most cancers are driven through genetic changes, but one of the interesting things about gastric cancer is that a good proportion of them don't specifically have changes in the genome, but they have epigenetic changes, or changes that are not specifically in the DNA, but in other aspects of the cell cycle itself that leads to the gastric cancer. In fact, one of the most exciting things that has risen from this whole concept is that we now have a targeted therapy against one of the proteins in gastric cancer called claudin 18.2, which is not known to be an oncogene driver, but we still have a drug that targets this protein and is now an effective additional treatment that we use for our patients with this cancer type.
Wow, interesting. There's just so much that we are learning. When somebody has gone through treatment for gastric cancer, what kinds of problems do they have afterwards?
So patients that have gastric cancer treatment have to deal with not only the issues that they face with the cancer itself, which is very often abdominal pain, bloating in the abdomen, and other sort of symptoms from the stomach cancer itself, but they also have to deal with the side effects that they have from the chemotherapy and the other treatments that they're facing. The chemotherapy itself has symptoms of nausea and vomiting, and specific to gastric cancer and other GI cancers is neuropathy. A lot of our drugs cause neuropathy, and this is numbness or tingling sensation that you feel in the fingers and toes, and this is very closely associated with a lot of the drugs that we use in gastric cancer.
Yeah. Well, we keep trying to develop drugs with fewer side effects that are more specific for the cancer. In our last couple of minutes, can you comment on some of the most exciting research going on related to gastric cancer, or for that matter, esophageal cancer? Where are we going, and what can we be hopeful about in the not 30-year time horizon, but let's say in the next 5 to 7 years?
I think gastric cancer and esophageal cancers are one of the most exciting areas of development in identifying therapeutic targets and drug development. There are multiple new targets that have been developed in this space. We just talked about claudin 18.2, where this is one of the first times we have a drug and a target that's first developed in gastric cancer, rather than most of the time we have drugs that are developed for breast cancer or colon cancer and then are tested out in gastric cancer. But we now have a drug that was first developed in gastric cancer. We have other new therapeutic targets that have multiple drugs that are being tested. One of them is FGFR2b, which we believe we're going to have a trial that's reading out in the next month that has another positive result. So we may have another therapeutic target. And this brings us to the idea of precision oncology in gastroesophageal cancers, where we're identifying specific targets and the right patients to treat with the right drugs, rather than blanket treating everyone with chemotherapy. We also have more elegant ways in which we're using these targets. We don't necessarily treat them with just monoclonal antibodies. We have antibody drug conjugates. We have bispecifics that are also being developed. And at Yale, we have many of these clinical trials that are open for patients to consider enrolling in.
Sure. And if I can just interpret for our audience for a second, antibody drug conjugates are antibodies that are linked to a little dose of chemotherapy. So the antibody acts as the delivery truck, and the chemotherapy comes in and ideally attacks the cancer itself and not as many of the surrounding tissues. And bispecific antibodies are antibodies that basically are two antibodies combined.
Absolutely.
Dr. Raghav Sundar is an associate professor of internal medicine and medical oncology and hematology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.